The second topic today for the posterior segment complications of cataract surgery is very important also, is the pseudophakic cystoid macular edema. Pseudophakic cystoid macular edema first described in 1953 by Irvin and first documented in 1964 by Gass. So the name was Irvin-Gass syndrome. Most common cause of decreased vision following cataract surgery. What types of pseudophakic cystoid macular edema? The first type is the angiographic cystoid macular edema. It's represented 15 to 20% of the cases, and it's not associated with any significant visual symptoms. The second type is clinical cystoid macular edema. It's range from 1.5% to 6.9% and associated with visual acuity of 20/40 or worse. But today's definition is becoming stricter. It's only if 20/25 or less, we will consider it pseudophakic cystoid macular edema. This is due to higher patient expectations. How to predict the pseudophakic cystoid macular edema? Preoperative risk factors like diabetes mellitus, hypertension, cardiovascular disease, old age, white race, and pre-existing ocular inflammation like uveitis and like this. Intraoperative vitreous loss, anterior chamber IOL, use of intracameral epinephrine and vancomycin. Postoperatively, vitreous attached to the wound. You must suspect anything of this. How to diagnose pseudophakic cystoid macular edema, which is very important. The first type, the angiographic cystoid macular edema, is asymptomatic. There is some form of decreased visual acuity, metamorphopsia, and central scotoma. The onset of pseudophakic cystoid macular edema is always from 4 to 6 weeks following cataract surgery, but up to 12 weeks it can happen. Cystoid macular edema may occur many years after cataract surgery. The signs of pseudophakic cystoid macular edema, it involved loss of foveal depression, increased macular thickness, increased intraretinal cystoid spaces, epiretinal membranes, foveal cyst, lamellar macular hole, and full thickness macular hole. What is the investigation we must do for a case of cystoid macular edema? The first thing is the fluorescein angiography. In the early phase, we will see capillary dilatation in the perifoveal region. In the late phase, there is a leakage and pooling of dye in the macular cystoid spaces. This is the petaloid pattern, which is very common and the very important sign of fluorescein sign of the cystoid macular edema. There is some often patchy hyperfluorescence is seen extending beyond the cystoid spaces, this widespread capillary leakage. As an example, there is a 50-year-old diabetic male underwent uneventful phaco plus IOL 1 month ago. His vision does not improve more than 2400. Fundus examination revealed bilateral macular edema. Fluorescein angiography and OCT pictures are provided. How can we differentiate cystoid macular edema after cataract surgery from macular edema of the diabetic patient? We'll see now. Which eyes underwent cataract surgery? We'll see here, this is colored and red free. Now we will see, this is for right eye, the fluorescein angiography. We will see here, there is a leaking all around the macula at the end point, around the macula here. If you look, this is the other eye, there is also a leakage around the macula. But what is the difference? How can we know which one is a pseudophakic cystoid macular edema, not a diabetic macular edema? Let us to look here. There is a difference here. There is a leaking here around the macula. Here the petaloid appearance. This is a characteristic, but the most important sign and very important, and a lot of people don't know this sign and don't concentrate with this. This is a hot disc. You will see here the disc in the right eye. The disc is, there is a hot or hyperfluorescence around the margins of the disc. Here is not in the other eye. So this right eye is the one with a pseudophakic cystoid macular edema. As this is the answer I told it, search for the late phase of the fluorescein angiography, late leakage from the disc capillaries giving rise to the late staining of the optic nerve head, what we called hot disk. This is post-operative cystoid macular edema. This is the OCT of this case, as we see, this right eye, here, cystoid macular edema, here there is a macular edema, this is diabetic macular edema in the other eye, as we see the difference in the number. Here, look for the hot disk. There is a cystoid macular edema, we saw betaloid appearance around the macula, but the hot disk is the characteristic of post-operative cystoid macular edema. Here also there is a hot disk, even it's not that characteristic betaloid appearance, but there is a hot disk with the edema. The second investigation we must do is the OCT. Why? Why we do OCT in a case such like this? The first thing is the quantitative assessment of retinal thickening, that then to exclude the vitreomacular traction and monitoring of the response to the treatment in the follow-up of the patient. What's the criteria we will find in the OCT? There is a retinal thickening and intraretinal cystoid spaces. In some cases, we will find epiretinal membrane or vitreomacular traction. This is OCT pictures of post-operative cystoid macular edema. These are OCT pictures for the vitreomacular traction. As we see, the macula from the center is pulled with the vitreomacular traction. There is a very strong vitreomacular traction, and this is one of the most important things we will take a benefit from the OCT for this, because it will give us a totally plan for the treatment of this case. This also, as we see, vitreomacular traction. What is the pathogenesis of pseudophakic cystoid macular edema? Till now, it's unknown exactly, but there is some theories. The first one is inflammatory theory. In inflammatory theory, ocular surgery results in release of inflammatory mediators which increase prostaglandins and leukotrienes production, leading to breakdown of blood-ocular barrier and cystoid macular edema. The other theory is the mechanical theory, which is the vitreomacular traction. This diagram shows the pathogenesis of pseudophakic cystoid macular edema. Here, the ocular surgery lead to release of inflammatory mediators, phospholipase A2, then phospholipids and arachidonic acid. Arachidonic acid, cyclooxygenase and lipoxygenase, then leukotrienes and then prostaglandins. All the inflammatory mediators will be released. The important thing on this arm and this arm of the cyclooxygenase and its ingredients, it's inhibited by non-steroidal anti-inflammatory drops. The other one inhibited with the corticosteroid. This will help us to understand why we are using this in the management and even in the prophylaxis. Now, what is the management of pseudophakic cystoid macular edema? What's our goals in treatment? Our goals, number one, to prevent cystoid macular edema. Number two, to improve visual acuity by decreasing macular edema. Number three, to prevent the complications as a foveal cyst, lamellar hole, and full thickness macular hole. There is a comparison of topical non-steroidal anti-inflammatory drops and steroids in reducing incidence of cystoid macular edema. There is some patient which underwent cataract surgery. We divide it in two groups. We give one group post-operative non-steroidal anti-inflammatory drops, the diclofenac, with steroid drops, okay, in the form of topical diclofenac and topical prednisolone. And we follow these cases. And the other group, we give post-operative corticosteroids only. What's the result of this study? It's evaluated after 6 weeks. The group 1, there is a 0% cystoid macular edema, post-operative. The group 1 is the one we used the topical non-steroidals with the topical steroids. The other group, the group 2, which we used steroid only, is cystoid macular edema happened in around 12% of the cases. Majority of the patients with cystoid macular edema have persistent reduction of the contrast sensitivity and color desaturation in spite of the treatment and in spite of cure of the cystoid macular edema. So the best treatment for post-operative or post-cataract cystoid macular edema is prophylaxis. Pre-operative use of topical non-steroidal anti-inflammatory drops 4 times daily from 3 to 7 days pre-operative and 4 to 6 weeks post-operative in combination with post-operative steroid drops or prednisolone minimize the incidence of cystoid macular edema. Now this diagram shows our plan to treat or to manage a case of post-operative cystoid macular edema. First of all, there is a clinical diagnosis that we clinically diagnose it as pseudophakic cystoid macular edema. What is the second step? Second step to do fluorescein angiography and OCT. Then after the result of fluorescein angiography and OCT, we look, this is especially from the OCT, if there is vitreomacular traction or no vitreomacular traction. If there is a vitreomacular traction, so we will go ahead for surgery in the form of vitrectomy and separation of posterior hyaloid with or without internal limiting membrane peeling. On the other hand, if there is no vitreomacular traction, we will go for a stepwise approach in the form of, we will give at first combination of topical steroids and non-steroidals. Some people prefer to give posterior subtenon triamcinolone plus topical non-steroidals. The third thing, if there is no improvement, we will make an intravitreal injection of triamcinolone or plus or minus topical non-steroidals. And then the last thing, if there is no improvement, we will go for vitrectomy with ILM peeling. This is what we told in the diagram. If there is no vitreomacular traction, we will give in a step 1 topical non-steroidals with topical steroids for around 6 weeks and then re-evaluate again. After 6 weeks, we will repeat the OCT again and we will see if the patient improved, it's okay. If not, we will go for the second step. If the patient is steroid responders, we will give only non-steroidal and we will also follow for 6 weeks and then we will reassess again. Step 2, we will give posterior subtenon injection of 20 milligram triamcinolone, 0.5 ml. Recently, many surgeons add topical non-steroidals. Step 3, there is an intravitreal injection of 4 milligram triamcinolone. This is 0.1, and some people prefer to give 2 milligram only. And there is a studies papers. There is 2 milligram and 4 milligram, the same result. And the advantage for the 2 milligram triamcinolone intravitreal injection is its complications regarding glaucoma is less than injection of 4 milligram triamcinolone. And some people prefer, even with the injection, to give the patient topical non-steroidal drops. Step 4, we will go for parsiplana vitrectomy and ILM peeling. What is the rationale for this? We must take it a stepwise, better to jump from the start for injection and like this, because there is many people with the topical steroids and non-steroidals within 1 month to 6 weeks, they improve totally and everything become okay. If there is a vitreomacular traction, we'll go directly for parsiplana vitrectomy with or without ILM peeling, but we must be sure that we remove the posterior hyaloid to remove the traction on the macula. And for me, I prefer to do internal limiting membrane peeling. Is there is a rule for other lines of treatment? In this video, we will show the removal of vitrectomy with the removal of internal limiting membrane or peeling of internal limiting membrane. Now we are making stripping of the posterior hyaloid, which is the most important step in the surgery. Now, as we see, the posterior hyaloid is detaching. If you look here, this is the edge of the posterior hyaloid. We are stripping upwards. And now we are completing the vitrectomy. Then I am injecting dye to stain the ILM. Now this is with the Tano scraper. We remove most of it. As we see here, the area around the macula is clear. Sometimes, as in this case, it's very tight and adherent ILM. So if I try to remove with the forceps, it's every time I try to pull with the forceps, it's resistant and it's cut. So I try to remove it with the Tano scraper. As we see now, this is the remnant of the ILM. I will remove with the forceps. As I told you, it was a very adherent and very tough internal limiting membrane. And even after removal of the ILM and the vitrectomy, there is some surgeons prefer to inject Kenacort, intravitreal Kenacort at the end of surgery, and some they don't prefer. Cystoid macular edema is the most common post-operative complications of cataract surgery, even if the cataract surgery is uneventful. Prophylaxis is the best treatment, which can be achieved by preoperative use of topical non-steroidals. Fluorescein angiography and OCT are crucial for the diagnosis of pseudophakic cystoid macular edema. Treatment will be a stepwise approach, starting by a combination of topical steroids and the non-steroidal anti-inflammatory drops. Parsiplana vitrectomy is reserved to be for the cases with the vitreomacular traction or in a resistant cases after other line of treatment fail. Thank you.